Okay, great. So my name is Alan Schroeder. I'm one of the co-chairs of this COVID in Children seminar series, along with Dr. Roshni Mathew, who I'll introduce shortly. Thank you all for joining today. We have now moved this session to occur monthly rather than weekly. It does not mean it's because we think the pandemic is over or 3/4 over. It just is that we covered a large majority of the topics that we had wanted to cover and now want to continue to provide these open forums to answer questions that are most pressing for our community, which is what we'll be doing today. But as we have periodically done, we will start today by having what we call an evidence quick hit by one of our trainees. And I'll introduce Neha in just a second, but and actually, Ingrid, we can stop sharing now, but that's the text code and the phone number will be placed in the chat if you want to get CME credit for this. Dr. Joshi is one of our pediatric hospital medicine fellows. She is our first return visitor for the trainee quick hit. She has always had a tremendous amount of intellectual curiosity, and I know she has been very engaged on the school issue. When we got questions submitted for today's session, actually the large majority of them had to do with immunization. We also wanted to talk about schools too. And so an article was published yesterday in Pediatrics about schools and transmission from New York City. And we thought that it would be nice to go through that article briefly. So take it away, Dr. Joshi.
Thank you, Alan. Can you see my screen now?
Yes, we can.
Right.
Perfect.
Thanks for having me. Welcome everybody today. Like Alan mentioned, I'm going to review an article that came out in Pediatrics titled COVID-19 Infections Among Students and Staff in New York City Public Schools by Verma et al. School reopenings and the safety for students as well as safety for staff members has been an ongoing conversation in every district throughout the country recently and in many households too. So we thought that this was an especially applicable study right now. For background for the New York City public school system, it serves 1.1 million children annually. This includes about 1,600 schools and 1,400 buildings. They serve anywhere from preschool all the way up to 12th grade. And like most schools, this school system was closed in March of 2020. At the beginning of the pandemic, and it actually reopened in September of 2020. So at the prior to the beginning of the 2020 to 2021 school year, all families were asked one of two options, which was to enroll in either fully remote learning or hybrid learning for the school year. Hybrid learning consisted of being in person for 1 to 3 days of the week, and then the rest of your learning would be remote. The mitigation measures for open schools included daily health screenings, masks for both students and staff members, 6 feet of physical distancing, stable cohorts, no visitors on campus, improved ventilation systems, and meals that were eaten indoors, but they were eaten within the classroom within your own cohort. What this study looked at was cases that were reported to their what they called their situation room, and the situation room received reports of COVID-19 cases from 3 different places. The first one was clinical laboratories. So by law, every positive COVID-19 test gets reported to the public health department, and it indicated whether that case would have potentially had any affiliation to a public school system. Secondly, so school affiliated persons, parents, staff members were required to report any positive testing that they got to their school. And then lastly, the school system conducted asymptomatic screening testing, which we'll talk about in a little bit. The study was divided into 2 different periods. The first period was October 12th through November 19th. At this time, it included approximately 300,000 hybrid learning students and 80,000 adults. The schools had asymptomatic screening testing a minimum monthly. Some of them had it as frequently as every week. Schools were then closed for 3 weeks surrounding Thanksgiving, and then period 2 started for the study between 12/7 and 12/18, at which point 164,000 students and 44,000 adults were on campus. At this time, all the schools had moved to testing asymptomatic people on their campuses weekly. The outcomes measured included the incidence and prevalence in schools compared to the community and the infection secondary attack rate. Here, there were amongst the asymptomatic screenings, there were 986 positive tests, which was the positivity rate of 0.4%, and this was across 1,594 New York City public schools. The median age for positive tests was 31 years amongst all testers. For staff only, it was 43 years, and for students only, it was 9 years. The highest number of those who tested positive were actually in K through 8 elementary and then preschool through second grade settings. However, the study didn't very well parse out high school settings versus middle school versus elementary school. So so just keep that in mind. So for period 1, when you combine all cases together through the 3 different methods that the situation room received, there were 1,259 school cases versus 44,000 community cases, which was a school rate of 341 per 100,000 and a community rate of 529. When you stratify by age, the incidence was lower in the school setting for all but the 65 to 74-year-old age group. A caveat here is that 37% of the school cases were actually missing the age data. For period 2, there are 972 cases in schools and then 42,000 in the community. Period 2 was significantly shorter than period 1, but had a similar amount of cases in the community, which reflects an increasing overall prevalence in the community. The school incidence was 464 per 100K and the community incidence was 509 per 100K. When you stratify these by age, the incidence was lower in schools for anyone less than 18 years, but higher for 18 to 74 years, which we'll chat about in a second. And similarly here, about 38% of schools were missing age data. Of those that were infected, 36,000 close contacts were identified, of which 0.5% of them tested positive. Of the 191 that tested positive, only 132 had sufficient information to infer disease transmission direction. And in the cases in the 132 that we could do this for, half of those cases were from a staff member to another staff member. A quarter of them were from a staff to a student. 14% were from a student to another student. And the remaining ones were. And then the secondary attack rate here calculated with the school exposure rate was 0.5%, and the staff was thought to be the likely index case in 78% of cases. This is a table from the paper, and the 3 columns that I have highlighted here are prevalence columns. And so there were 2 models that they looked at when you're looking at the community prevalence. Model 1, which is highlighted on the left, is from the Shaman group at Columbia University's Mailman School of Public Health. This model uses case mortality as well as mobility data, and it is thought to be an overall underestimate of what the community prevalence of COVID-19 is. The middle one highlighted is Model 2, which comes from COVID-19projections.com, which is this open course project that utilizes a machine learning model. And this machine learning model includes those who are recently infected, but no longer thought to be contagious. And so this represents kind of an upper limits bounds of what the community prevalence is. So the true prevalence in the community is thought to be somewhere between Model 1 and Model 2. The very right column is the school period prevalence, which is listed here. And then so in the 4 out of 8 weeks of this study, the school prevalence was actually lower than both Model 1 and Model 2. So we can safely say that this is likely a lower school prevalence than was in the actual community. For the other 4 weeks, the prevalence in the school was between Model 1 and Model 2. And so what we can likely infer is that the school period prevalence was potentially lower than the community or was somewhat equivalent to the community, but not likely to be higher than the community's prevalence. So what this means is that in-person learning in public schools was not associated with increased prevalence or incidence overall compared to the community, that the rates of school infections rose with the community rates. And then specifically in December, but a little bit throughout, the incidence is markedly higher in the staff and more so in the 45 to 75 age group, but the overall prevalence was similar to or less than the community prevalence models. So this suggests that the increased incidence was likely due to attributed ascertainment. An example of this was that the staff was tested at a rate that was 10 times higher than that of the community. Or it was potentially representative of acquisition of infection outside of the school with the rising community incidence. We've asked a lot about why school rates seem to be lower than community rates, and we don't have a clear answer to this. Some of the thoughts were that students and families who are choosing this hybrid option may be somewhat more rigorous in infection prevention measures. They may have also had a higher prior infection rate and thus potentially higher rates of immunity. And then potentially the hours spent in school may reduce the time that these students may have otherwise spent in higher risk community activities. There are limitations to the study, like any study. The first one is that it was prone to error through interview bias because families were contacted and discussed for the further contact tracing. It was limited by the fact that only 41% of parents consented for their students to be tested in that asymptomatic screening during period 1. And then lastly, like I mentioned, the age data was missing in 35% of cases approximately from period 1 and period 2, which may change the age stratification, but doesn't change the overall case numbers. So the conclusions here is that the incidence and prevalence was either less than or equal to similar to the community, suggesting that schools are not a large driver of new infections. And lastly, that further studies are needed to identify which mitigation measures are most helpful and how mitigation measures may fare with the full return of schools for the majority of students. Thank you.
That was great, Dr. Joshi. Thank you. And since I know you've been following this literature closely, there's now really a pretty large body of literature on school transmission. How would you say this study sort of stacks up and compares in terms of its conclusions to the rest of the body of literature?
I think the study is pretty consistent with what we've been seeing at school from studies from schools across the country, that the infections that we're seeing in schools are either less than or very similar to the community. I haven't seen a study yet where the school rates have been significantly higher than those of their community.
Great. Well, we can circle back to that because I know that our panelists today have been watching that data very closely and even studying it themselves. So thank you again so much, Dr. Joshi. If any questions come up about that study, please put them in the Q&A and we can either address them live or Dr. Joshi can type in some answers for us there. So we're going to move on to our main session, and I welcome back Dr. Yvonne Maldonado, who I think should be well known to all of us by now. She's now been on our seminar several times and is a professor of pediatrics, a division chief of pediatric infectious disease, and is leading all sorts of national efforts and studies on COVID in children and in adults. So really tons of really useful contribution, and really appreciate you coming back. And Dr. Mathew is an associate clinical professor in the division of pediatric infectious disease, and she runs our infection control efforts here at Packard and gets probably 15 phone calls a day about testing and isolation and all sorts of other things relating to COVID, and has just done tireless work on that front. So really thrilled to have both of you. We are going to focus, as I mentioned at the beginning of the talk, largely on vaccination today, because that seemed to be the driver of a lot of questions, but we hope to also cover variants and potentially schools as well. Obviously, those three things are all overlapping in terms of their relevance, but before we get into some of the questions, I've asked Dr. Mathew to just share some of the local data to give us some context into how things are going locally and beyond.
For this time and for making me a panel member, but I know a lot of questions today will be to Dr. Maldonado. I would like to share some of the data based on just epidemiological data, which might be of interest and can set the stage for our conversation. This is from the American Academy of Pediatrics, just telling us the cumulative numbers of pediatric COVID cases and hospitalizations. So there have been about 3 million total COVID-19 cases in the United States. That represents 13% of all COVID cases. So we are upwards of 25 million now in the United States. In terms of hospitalizations, children contribute 1.3 to 3% of total reported COVID hospitalizations. And that also translates to 0.1 to 2.2% of all children with COVID-19 have been hospitalized. In terms of mortality, Children represent 0 to 0.19% of all COVID deaths, and that again is 0 to 0.04% of all COVID-19 children with COVID-19 have died so far. This is the age distribution, and just as Dr. Joshi had just discussed about the prevalence, I think this is interesting to look at as well. So children represent about 13% of the cases, and the rest, and another 13 to 14% are this higher age group, so over 65 and over, and the rest of them are right here in the middle, and a lot of them are obviously members of our school staff. So considering that this population of 65 and older represent about 14% of cases, when we look at the deaths, however, you can see that that particular population represents about close to 80% of the deaths, although they represent close to children's numbers of cases. This is the LPCH Enterprise Analytics Group put together this dashboard. Basically, that shows the COVID-19 cases across the United States that is showing a nice downward trend. And in California too, this spike that we see is from July. And then we saw that huge spike in December, January, and then we've been seeing a consistent decline in the number of cases. This is our local Bay Area COVID-19 statistics. And these are all the counties of the Bay Area. The darker the color, the higher the total number of cases. But you can see that over the past week, we have consistently seen a downward trend in all counties. The right side, it shows all the counties on the top and a nice downward trend. And the purple one is our Santa Clara County. And that also has shown a decline in the total number of cases. Just to remind us, in California, at least we have this county risk level. And this is from, it goes from widespread, substantial, moderate to minimal spread. And this is based on the positivity rate. And we are currently, our Santa Clara County has moved from widespread to substantial, which, and hopefully we are going in the right direction on that one too. So that's why we are on the red tier right now. And this is the COVID-19. This again is from our analytics group that have put together this dashboard that looks at vaccinations across the country. We have had the percentage of population vaccinated with at least one dose is about 18% across the whole nation. And 10% of our population, which is about 31 million, have received both vaccines. And the percentages across all states are here. And California, we have about 19% of our population that has received at least one dose. And you can see the numbers are pretty comparable across all states. This is Santa Clara County vaccination data, and so you can see that this is from the dashboard from this morning, so it's pretty up to date. So that's all I had to share in terms of our epidemiology.
Great. Well, thank you for ending with vaccination, because I think we can launch right into that. And Dr. Maldonado, maybe I'll just ask, so 21% for Santa Clara County is certainly above a national average, a little bit above the state average, and that's and the state is above the national average for a state that seemed to get off to a slow start. So is this about where you would have expected us to be right now? And can you talk a little bit about what you see as being sort of the main rate limiting steps, the main areas that are preventing us from vaccinating more?
Well, I don't really know where I thought we were going to land. I thought initially if we tracked surveys from last summer until the end of 2020 around who would even agree to be vaccinated, the numbers were quite low and have gone up over time. But we also were kind of trying to contend with changing numbers of vaccine availability. So remember last summer we started with Operation Warp Speed telling us we'd have 300 million doses in December, and we wound up having about 10 million doses. So I'm much more optimistic now, but I think people are really getting somewhat anxious because we see that so many people in the higher risk categories are being vaccinated. And now that we've kind of started the process, all of the counties and all agencies around the country are starting to really get familiar with how to do this well. And now we're going through a dearth of vaccine. And I'll tell you why that is right now, because Pfizer and Moderna are moving along at their usual rate, but two things are happening. One is Pfizer and Moderna are now trying to ramp up production by teaming up with other providers. For example, Merck and Pfizer are working together. Merck had 2 unsuccessful candidates, so they figured they would team up with Pfizer to help them produce more vaccine. In the end, it's all about physical facilities to produce actual vaccine. So they're doing that, and Moderna will be also working with other partners to build out more vaccine production capability. But finally, when Johnson & Johnson was approved at the end of February or first week of March, which was actually last week, they had 3.9 million doses of vaccine on hand. They shipped that out right away, but they said, we don't have any more. We're shipping everything out now, but we promised to have 20 million total doses by the end of March. So we expect another about 16 million doses, but we have a 2-week lag time right now where we're going to have nothing. And remember, all of the vaccine was shipped out last week, and the state of California just got their doses yesterday. So there is, 24, 48 hours of lag time is anxiety provoking for a lot of people. And I think we just have to sit tight and be ready for vaccine when it comes. I'm pretty confident that we'll have another bolus of vaccine. We just heard this morning, I was on a call with the county, and they actually got extra doses of vaccine compared to last week where they got less doses than they were supposed to. And so we're probably going to be able to at least honor the vaccine appointments we have now. And that's not just us, that's around the county and hopefully the California as well. So the bottom line is it's all about, ups and downs, little peaks and valleys of production and operationalizing these giant systems that we've never, ever had to do in this country before. So I think all in all, we're doing not a bad job. Everybody is aware, and that's great news. And I think the fact that people are aware that this is important, that equity is important, that we need to vaccinate those who are sick, likely to become sick and die and be hospitalized. That is really an age-based determination, as well as healthcare workers, to protect the healthcare system. And I suspect that, as you all know, by March 15th, we'll be moving, which is this weekend, next Monday, we'll be moving to Tier 1C, which will include people 16 to 64 years of age who have underlying medical conditions. Unfortunately, this comes at a tough time because we have not enough vaccine to move into those categories yet. We're still trying to catch up with the others. And so people will be looking very hard to try to find a place to get vaccinated. And I think, unfortunately, we'll just have to see where people can go. Some of the big centers, the Alameda County, the Santa Clara and Alameda County Fairgrounds, the Oakland Coliseum, there's a lot of big places where they're giving 8,000 doses a day, for example. And I think people are just going to have to look. But in the next 2 weeks, I think by the end of March, we will start to see more supply. And I do think that by May, which seems like a long way away, but it's only, it's less than the time that it has been since we had our first approved vaccine. So we will get there. And I think the vast majority of the population of the US who wants vaccine should be getting it before this summer.
So you brought up the J&J vaccine, and as you mentioned, we just got a shipment in the Bay Area, I think yesterday or the day before. So people are going to probably be given the opportunity to get the J&J vaccine, and obviously, if you don't have to look far to read that the efficacy reported, at least the vaccine efficacy for infection, is lower than Pfizer and Moderna. What can you say about that, about safety, and about sort of comparing or weighing, take what you can now versus wait for a better opportunity?
Yeah, I have to say, I've been working with vaccines my whole career. I would get any of them right now. Doesn't matter. If I had the opportunity to get one, I would take whichever one I was offered. And I'll tell you why. 66% efficacy of Johnson & Johnson in one shot to prevent disease, but across all three, 100% protection against hospitalization and deaths. Equally likely protection against variants, which is actually pretty decent at this point. So, there have been some breakthrough cases, but they, again, zero hospitalizations, 0 deaths. So there may be a bit higher risk of getting some symptoms, but the way J&J was done is very different from Moderna and Pfizer. So we have to retake that into account. J&J came around, was first studied right in the midst, in countries, right in the midst of the increase in variants. The other two came before the variants, and it actually worked quite well against variants and against disease. The other thing that's different is the J&J vaccine used terms like moderate and severe disease, which if you look at the comparison of symptoms to Moderna and Pfizer, they would have been called mild disease. So in most cases, so most of the people who actually broke through, again, no hospitalizations or deaths, but we're talking about people who had a cough and chest pain or shortness of breath, but didn't require hospitalization. And we see those patients all the time in our outpatient trials, and they do fine. Obviously, nobody wants to be sick, but the illness is quite mild. The other issue around safety, I'll say two things. One is, one of the cool things about the efficacy that we're starting to see indirectly, there's no direct data yet, but indirectly, it looks like all three vaccines provide between 50 and 75% protection against asymptomatic infection as well, which is really exciting. That means that we will probably be less likely to transmit disease. Now, the models are being built now to see, will that decrease in transmissibility from being vaccinated equal or best the risk of the infectivity of the new variants? And so there's a little bit of a race going on there. And in the end, we'll have to see, but I suspect that if the variants are between 30 and 50% more likely to be transmitted, but you're seeing a 50 to 75% reduction in transmission from being vaccinated, I suspect vaccine will win out. But we'll just have to see how that plays out. So that's really good news. And then the last thing I know people talk about, and they talked about the mRNA platform as well, because it's a new platform, but for adenovirus vectors, the adenovirus vectors, people worry because these are DNA viruses, can they integrate into the genome? And this vaccine and has been, it's an adenovirus 26 virus vector with the spike protein gene, cDNA complementary DNA integrated into it. And it is non-replicating in humans, and it is designated by the FDA as a non-integrating virus. And in fact, I look back at the literature, and there have been some reports back in 2010 or so of these platforms integrating into cells, but those are the replication competent versions and not when injected into humans. So for example, as a vaccine. So these are not going to insert, this genome is not going to be inserted into the human genome upon injection as a vaccine.
So no concerns then from your perspective about using it, say, in immunocompromised hosts.
Right. Obviously that's being tracked, but the FDA has already, indicated that it's integration. I don't know if incompetent is a word, but it's not a non-integrating platform.
And any other information or guidance on general safety of the adenovirus, the J&J, as compared to the other two?
Yeah, I mean, I think in general it's a little less reactogenic, but it's still reactogenic. It's a little too early to look at safety signals. Of course, Grace Lee is chairing that committee at CDC, and it takes time to gather enough data to really look at it through VSD or VAERS or the other systems that are being looked at. And if you look at now, we have data on Pfizer and Moderna, and what was nicely being shown is that the safety signals people were most worried about, that is Bell's palsy and Guillain-Barré have not been shown to be a problem in this group compared to controls. So that's reassuring. And we're talking about millions of doses now. And the anaphylaxis rates are about 2 per million doses for Moderna, and actually has dropped for Pfizer as well, down to about 4 per million doses for Pfizer. And by comparison, about 1 or so per million for influenza vaccine.
Yeah, it just bears repeating how much these vaccines have exceeded almost everybody's expectations, both from an efficacy and probably from a safety perspective as well. So it's just so encouraging to hear that. Moving on about vaccines, we get a lot of questions about kids. We not only when we're going to immunize kids, but people wanting to volunteer, either their patients or their own children. My 13-year-old thinks it's his ticket to sleepovers. So what do we know? I know Stanford was approved for a trial, but tell us what's on the horizon.
Yeah, we're really excited about that. And I think part of it is because we were already, and I want to thank my colleagues in OBGYN, especially Natalie Aziz and her team, because I had already started a trial on maternal RSV vaccine, and we're in the middle of that trial. It's going to be extended because obviously we didn't see RSV this year, so we don't really know how efficacious that vaccine will be. But because of our connection with that Pfizer trial, we were asked to be considered for participation in the Pfizer trials. And we will be starting, we don't know for sure yet. I have a call later today with the Pfizer CRO, the research group that helps us put the studies together. And we are thinking May or June, and we are absolutely excited to look for volunteers. So we'll be putting out information, and I don't really know what a central way to do that is, but if you have suggestions, Alan, we're going to be putting out flyers, and we'll have a central number at some point. We don't have it up yet, but May or June, and it'll be a phase 2/3 trial. I don't have a dose yet or anything because they're still finishing up the phase 3 trial, because the phase 2 is just being finished now, around dosing and dose amount and how many doses. And so it'll likely be a 2-dose regimen, but the amount isn't clear yet. So we will have something May or June, and the age groups will be 6 to 12-year-olds, because it turns out all of the companies, so Pfizer already has a 12 to 15-year-old study that it's completed. They're analyzing the data, and they're hoping to submit that data. And we were talking to the American Academy of Pediatrics yesterday, because they've been in touch with the federal government around how to consider moving forward with an EUA, an emergency use authorization application to the FDA. So we've been helping advise them around that. Of course, the main issue is safety signals and how long to wait around safety signals for kids. But those data for 12 to 15-year-olds is already accumulated, at least for Pfizer. Moderna is almost done as well. And the other vaccines, Johnson & Johnson and AstraZeneca are starting to do trials in those age groups as well. So we'll be starting with 6 to 12. And actually, there's some indication that they may want us to help with a phase 1 study of about 35 children or so for a phase 1 in 6-month-old to 2 to 5-year-olds, so younger kids as well. But realistically, as you heard, I think Dr. Fauci say yesterday, probably I wouldn't be surprised if we have a vaccine for preteens and adolescents by fall, but for the younger kids, probably not quite that quickly, unless things go very quickly at this point. But at least for the 12 and older, there should be 1 or more vaccines available by September, and we'll see what happens with the others.
Dr. Mathew, you talked a little bit about kind of the clinical burden of COVID in kids so far, and of course we've brought up on this seminar several times, and you and I are trying to study this right now, but the fact that perhaps the hospitalization rate is a little bit inflated because of universal screening. I'm envisioning a summer where hopefully, as Dr. Maldonado suggests, most adults are immunized, prevalence will be lower, We've known that kids aren't getting as sick. How are we going to think about the risk benefit profile for our children?
Yeah, I think this is a great question. I do think that although we don't know about comorbidities and how that impacts children, we do see that there might be certain comorbidities that actually make certain children at higher risk of disease. So that population, I think, is easier. And for the healthy children without comorbidities, we do see rare complications like MIS-C. I must say, thinking back to all of our MIS-C cases, they have all occurred in children with no comorbidities. These were previously healthy children whose initial COVID infection was either asymptomatic or very mild. So it's unclear what makes certain children go on to develop complications, but that is, although rare, a real entity. And so that might also sway us towards thinking that children should be immunized. And I think with the safety data that will come up, I think that's the main issue about immunizing children is weighing the risk benefit. If COVID is not as impactful to children, but if the safety data shows that it is safe, I feel like as parents, we would feel like that's a good strategy, just like we do influenza. Most of our children are not going to be hospitalized with influenza if they are not having other underlying issues, but we do vaccinate them. So I do imagine it to be a similar situation.
Well, the additional part of that, I guess maybe Dr. Maldonado, you can add on to whatever Dr. Mathew said, but additional to that, we don't know exactly what the duration of immunity will be in adults for immunization. So I suppose immunizing kids may mitigate some of those concerns. But what are your thoughts on how we can sort of convince parents that the risk-benefit profile is indeed favorable? Dr. Maldonado, there were a couple of questions in there that maybe you've already answered about duration of immunity from the vaccine, and
Sure.
to the extent that immunizing kids may mitigate some concerns about suboptimal duration of immunity. But maybe you can answer what little we do know about duration of immunity at this time, and then any thoughts you have about how we can sell the parents of children on the risk-benefit profile of the immunization.
Yeah, so first of all, around T and B cell immunity, I think we have experience with other viral diseases and vaccines, and we know that these vaccines, such as these, meaning other viral directed vaccines, do elicit T and B cell responses and memory responses. And generally what tends to happen is you develop some degree of a memory response. You may lose your antibodies and you may have an anamnestic response over time. And what generally tends to happen is you may not have fully protective immunity, but you build up a bit of a repertoire of some mitigation of full-blown disease. So we don't really know yet what that means for this virus because it's new. But I agree that there's likely to be T and B cell a long-lasting immunity. The question is, how long will that last and how protective will it be? A good example, of course, is influenza, where we know that despite the lowish effectiveness of those vaccines, meaning they're between 20 and 60% effective over in different years, that when you have a brand new strain of flu, you get a really tend to get much more serious infection, suggesting that even if you don't have effectiveness against disease overall, you're still mitigating the symptoms because you have some memory. And so I think that we'll have to see that play out. And indeed, so far, there have been studies looking at T and B cell responses, suggesting that there is good stimulation of that immune response. And around safety, these vaccines, again, I was a skeptic last year too. We were not sure what was going to happen because these vaccines rolled out very quickly, but we were able to hear Melissa Moore speak on Monday on International Women's Day, by the way. And she's actually a chemist, a PhD chemist that works at Moderna and was really responsible for a lot of the trials of Moderna. And she talked a lot about this platform. And we've known about mRNA platforms for a long time, for many, many years. They were first discovered, the mRNAs were discovered in 1961. So we've known about them for almost 60 years. And we've been using, there have been studies around them as a vaccine platform, but because there had been, it's very hard to move from conventional, well-known platforms to new platforms. That's been the case with flu for many, many years, where we've had newer cell culture-based flu vaccines, and people have not wanted to get away from the old egg-based culture systems because they work. And so I think it took a pandemic like this and a lot of money to really get us to understand how well these platforms work. And in fact, the company is now, at least what they showed us on that talk, and if you're interested, you should look, it's the McCormick Lecture, which I fund through my office in the Dean's office. And if you look for the McCormick Lecture, it's recorded, but there are at least 10 other vaccines that they're starting to look at with an mRNA-based platform, and they're quite safe. We've talked about that in the past year, so I won't go over that. But again, the J&J, the platform itself is very safe. So they haven't been used primarily because people have been pretty satisfied with the old platforms. But I think we're moving, as we have with telehealth and many other things, we've started to discover that there are other technologies we can use that are effective, and we are tracking safety. And like I mentioned before in another discussion, we are still with CDC and AAP tracking safety of all our vaccines, even the ones that were licensed 20 and 30 years ago. So we always track safety of vaccines just to see whether there are differences, whether we still need them. And I think at this point, again, there have been, with millions of doses given already, the safety signals have been very low. And the only thing specific to children would be this idea of MIS-C. And there's no evidence from an immunologic standpoint that pathway seems to be triggered at all by infection or presumably by vaccination, although that will be tracked in the clinical studies. But there's no evidence that that is a concern. It needs to be tracked to prove that, but there's no biologically plausible reason to think that would happen.
Yeah, thank you. We get that question quite regularly in terms of potentially being a concern relating to the vaccine. A couple questions that are popping up here. One asking about type 1 diabetes and why that's not, it's a pretty specific question, why it's not included in phase 1C list of high-risk medical conditions for 16 to 64-year-olds. Any thoughts on sort of how we're defining chronic conditions?
Yeah, it's hard to know. Remember, a lot of these were put together based on clinical experience. So it's kind of a circular argument. If you see people being hospitalized for something, you're going to use them as a risk group, and then you may actually continue to reinforce that group is at higher risk than, say, other groups, because the others may not be on your radar. And I think one of the things that's hard to tease out, which I haven't seen good data for, is the potential confounders of obesity and diabetes, type 2 diabetes. As it turns out with children, if you look at risk factors, 52% of children who are hospitalized, who are infected with SARS-CoV-2 have underlying comorbidities, and that by and large, the biggest factor is obesity, accounting for a large proportion of underlying comorbidity in kids. And then the second one in kids is asthma, and that's not actually included in some of the risk conditions, but it's actually the second most common in children, although really only around 10% of kids who've been infected have had that as an underlying condition, but it's still the second most common. So the point is that type 1 may be a marker of infection. We don't know that. And I think to reflect that, the California Department of Public Health has said that providers have some discretion in deciding whether their patients are at high risk or not, but they gave guidance around certain conditions. And different healthcare systems are handling that in different ways. The idea is not to provide to provide as much opportunity for people to be vaccinated rather than to put up obstacles. So in many cases, for example, people are going to their providers or they're being asked to self-attest. And in some cases, they're not as granular, saying type 2 diabetes with a hemoglobin A1C greater than 7.5, which is incredibly specific and really would probably not serve our population well to just get as many people who are diabetics immunized. So all that to say that I'm not sure that there's a really good biological reason for that, but it may be confounding with obesity, and those things tend to go together in some cases, and not good data looking at other conditions. So we're just worried overall, for example, people with cystic fibrosis who just in general would not do well with respiratory infections. So you probably would consider them risk, even though there aren't any really hard data at this point to suggest that they're at more risk with this virus than other respiratory viruses.
A couple of questions about 16 to 18-year-olds, and now technically they could and should be vaccinated if they fit into either one of the vulnerable populations or healthcare or food and agricultural workers. Is there can they get vaccinated at Stanford? Any insight into where they should go?
Yeah, so they are actually eligible right now, but they can only get Pfizer vaccine because that's the only one that's approved for 16 to 17-year-olds. And at this time, as you all probably know, we had to reschedule all of our appointments for the next week or 10 days or so because we, as I mentioned earlier, we did not have enough vaccine for first doses and we need to get, our priority right now is to get second doses done. And so we didn't have enough doses to finish up second doses and then get to new first doses. So we moved all our appointments up about 10 days. And we're hoping that we will get more vaccine in the coming week. We just heard, as I mentioned today, that the county got more vaccine. So we'll wait to see. Our allocation looks pretty decent for next week. But we'll have to wait and see what we get on Tuesday. Usually the shipments come in on Tuesday, and then we'll have a better idea. So Stanford Healthcare should have appointments open at some point in the next few weeks, but we're telling people to try, but right now we're just not opening up new appointments until we get those doses in our hands on Tuesday. In the meantime, go to myturn.gov. I think it's myturn.ca.gov. And that will tell you where you can go, where is the closest place to find a vaccine center where you can make an appointment. And each system will be different. Most of them ask you to attest that you will fit in a particular category, and some of them will be very specific about what you need to bring in, like for example, some people are asked to bring in a pay stub. If you say you're a student, an educator, and let's just say you're a PhD student and you're teaching classes, you will bring in evidence that, first of all, your ID to show who you are, then your ID from school, and then maybe a pay stub to show that you were paid. So indicating that you were not only a student, but being paid to teach. So you be careful when you go in to make your appointment that you read everything, and it'll tell you what IDs or what documentation you might need to bring in.
So I want to ask a few questions relating to transmission after immunization. And Dr. Maldonado, you alluded to this a little bit already, that we've seen fairly encouraging data on that so far. But we've had some pre-submitted questions, and at least one that's popped up now about sort of how doctors should be sort of carrying on at this point. And the first question, maybe Roshni, you can answer, that had to do with double masking, which seems like we're sort of going in the opposite direction, given that we're now immunized. But obviously there was some recent recommendations that double masking may provide more benefit than single masking. So maybe you can weigh in on that. And that was specifically in the outpatient setting. But also I want to just ask you guys about all of our educational venues, our conferences, our care conferences, our educational conferences, lunches together. CDC has now said small gatherings are okay. What do you guys think in the hospital setting? But maybe the first one about double masking, Roshni.
Yeah, so that particular guidance came from CDC based on an experimental study that they did on mannequins. So Dr. Maldonado and I very well know about experimental versus real life, and we have struggled with this right from the start of the pandemic. But anyway, so that's where the guidance came from. CDC basically, they did this experiment where they looked at different strategies to help fit the mask properly. So that was the whole goal of that experiment, was to figure if well-fitting masks actually are better. So in that study, they found different techniques in which the mask could be fit properly. One of that was to tie a loop, and the other one was to use a cloth mask over the other mask, and they found that to be a better fit mask. And this is not really for healthcare purposes, because in healthcare, we use masks that are rigorously tested for fluid and for other different ways in which they make sure the mask is actually useful. So the bottom line is the CDC was trying to say you need to have well-fitting mask. And this was one of the strategies they used, was to use double mask. The problem with that was also that the cloth mask was studied over the regular mask. And that's, from an infection control standpoint, that could be an issue, because that cloth mask should be cleaned, and we cannot assume that that's going to happen on a regular basis for everybody. So they did not actually test the other way around. So all in all, to say, our current strategies, whatever we've done for the past year, has worked. So there is no particular reason to change our stance based on that one experimental model study. In terms of the CDC's newest guidance on vaccinated individuals, that particular guidance was mostly for outside of healthcare and for family gatherings and things like that. So that's how they put that statement out. For the healthcare, though, so we cannot ask individuals in general, are you vaccinated? So when we say in a healthcare setting where we are in conferences, we cannot assume that everybody in that room, for example, is vaccinated. So at this moment in time, we have not changed PPE based on that in our healthcare environment. But I'm happy to have Dr. Maldonado also expound on that topic.
Well, I thought Roshni was going to have the answer. The answer is that we don't know yet. We're going to have to, luckily, we're going to go to this point. And I remember at the beginning of the pandemic a year ago, thinking about moving into all these tiers and thinking, well, when and if we ever get out of this, well, no, not if, but when we get out of this, how are we going to peel things back? Because it's really hard to back out of things when, you're so worried that you're going to have another surge. And, by the way, the numbers have kind of plateaued. So if you look at the numbers today, I looked this morning, we are still at the peak numbers for the summer surge. So we're much better off than we were in December, but we're at the peak of where we thought we were panicking back in the summer. So it just goes to show you how we, beings are very resilient at getting used to tough times, which is good, but we're not anywhere near where we should be at this point. We're still pretty high up and we're stalling out. So I don't know why we're stalling out. I don't think it's the variants. I think people are just loosening up a little bit. And that's not to say that we shouldn't get out and start doing things, but I'm worried about how we can roll out, the CDC guidance in a hospital setting without intruding on individual rights. We don't ask those questions of people in general. So I don't know how we're going to do that yet. We're all trying to figure out whether the county will help us with further guidance. And we really do lean on the county because they are the ones who tell us how we should proceed. And if they give us general guidance, we can be more granular, but we certainly want to start to plan to open up more, especially in non-patient care areas. So we have been talking about, probably over the summer, maybe if things are, doing as well as they are now, maybe looking at non-patient care areas and being a little more, less restrictive. But we don't really know what that means yet. And we're already trying to plan on what to do. But again, we really do need that guidance from the county. I don't know, Roshni, what else you think, but that's we're kind of stuck right now. But it's a good place to be because we do have some options.
Well, I promised we would dive into variants, and we have a little bit, and you just mentioned them. But can you just tell us? I listened in on Ben Pinsky's quick description yesterday morning, and it seems like mostly here what we're seeing is what we're calling the California variant. But tell us, how scared are you? What are we seeing here, and what can we expect?
Yeah, so I'm part of a COVID vaccine network, and we work with across the country with NIH and other groups. And there's a really nice group up at the Fred Hutchinson Center up at in UW, and they do a really nice job with this program I've been following since last year. It's called nextstrain.org, nextstrain, one word, .org. And you can track the viruses, phylogenetic evolution over time. And it's very interesting to see how that's happened. And that's going to be normal. That'll happen. Viruses just change. They mutate. What's interesting about this virus is it seems to have potentially a selective area around the receptor binding domain. So if you look at the variants across the mutations across the genome, they're really randomly scattered, except for when you get to the point around the spike protein that attaches to the cell. And that's where you see lots of variability overall. And so that indicates that the virus the mutants are better able to attach. And what we're seeing with the variants now is that they have, we do think that the UK variant is more likely to be the predominant circulating strain. And there are some data that just came out this morning that indicate that people who had the variant in the UK had a higher death rate than people who didn't have the variant. So I'm not sure why that would be. And there's a lot of confounding. So it was a retrospective case control study. So it's hard to know what that means biologically. Why would attaching better make you more virulent? So I don't know if it's more infectiousness or higher titers or what it is yet. So the point is that we're racing against these variants. If we can be vaccinated, I think we can reduce the little laboratories that we are and not be an experimental site for the virus to mutate and try out new versions of itself. So less exposure by more vaccination and continuing distancing is going to be helpful. I'm not super worried at this point with the current types of variants. What I'm worried about is that there might be some strange new recombination that could happen down the line, but that can happen with any virus that we see in our world. And so the likelihood that that would happen is very low, but of course, this was not very likely to happen either. I do think this indicates that we need to start planning for future viruses. And I know we're running out of time, so.
Well, maybe just the last, there was a submitted question and a couple here about pregnancy. So maybe just maybe 1 minute about vaccinating. Safe, is it safe? And if so, when is the best time?
Yeah, so so when we're going to meet with CDC, ACIP, I'm on the Red Book Committee, and we met with CDC and ACOG and a few other than MFM, Maternal Fetal Medicine Group. And we talked about these vaccines and what they thought. And they had a number of placental immunologists in their group and others who really study reproductive health. And nobody was concerned on their end from the ACOG end and the maternal MFM group about safety. The vaccine itself, when you look at it, the mRNAs and the adenovirus vaccines did not raise any safety signal issues with any of those societies. And of course, as pediatricians, we're happy to support whatever these groups thought. And so there's no, again, at this point, there's no biological reason to suspect that there's a safety issue. On the other hand, we do know that women who are pregnant are more likely to be hospitalized and to be in the intensive care unit. Now, they don't have a higher risk of death. That was actually not a great study, so I'm not super thrilled to quote those data, but it's what we have. But we do know that at least from that data those data that were presented, that when pregnant women do have a higher risk of intensive care. So for that reason, I think vaccination of pregnant women would not be contraindicated. And there are trials going on in pregnant women, and people worry about, well, why is that? Are they not safe? And it's really to look at further safety signals in pregnant women themselves, as well as efficacy, getting a better handle on efficacy data for pregnant women. So right now they just say there's no recommendation from CDC. They say they should be counseled and they can make a decision with their provider, but there's no safety signals that have been raised. And of the about 2,000 women that have been reported so far who've been vaccinated, there haven't been any signals at all. In fact, in some cases, they just by random chance, they actually turn out to have less adverse events compared to control. But again, 2,000 is not a big number.
Okay, well, we're a minute over. Thank you again, as always, and we will do this again for the community in about a month and take your questions beforehand. I apologize that we couldn't get to all of them today, but I hope we covered most of them. Thank you all so much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.